for you guys to view now. So yeah. If you want to try to do the questions, you can do that. Okay. You can look it up in your textbook. If you need to use the desk beside you for your books, y'all can do that too. There's not enough space in there. Do you guys have a little bit better feel about the quiz now that you've done one and how it's going to work? That we're going to cover that material today, so you've read over it and maybe you come to class with some questions, or hopefully after I give you some of the information, I'll give you some clarity on what you were reading. I know this week has been a big week of terminology, and somebody had asked me about that, but in dental assisting, we don't do one strict course of terminology. We just pick it up in each individual class. So it's not like you have one set test of terminology. One section of this class will be a lot of terms, and you'll see that listed as morphological terms kind of on the way down. But we use those terms to describe anatomy of teeth and other things, so you'll see how we'll use it on the test. So it won't be just like a lot of terms typically on one specific test. Is how we use it. So you see between lecture, myself, Ms. Pruitt, Ms. Christopher, that we use some of the same terms, or you'll hear me talk about things that we've talked about in this class and how it overlaps some. Okay, so let's see. Okay, very good. For this one, Filtrum was correct. Most of you answer that. All right, there's the next one. This is just a little bit of a review. So typically when I come to DEN 100, I typically review a little bit of what we talked about from the time before, and then we move forward. To lower everyone's stress level, we will not have a test on Monday because we'll be lucky to get through a bulk of material that we need to get to for the test. But typically what happens is I'll move the test to next Friday. And any of the material that we're ready to start that would be new and not on the test, I'll just kind of give you a dividing line in your notebook so that we don't get any farther behind, and we'll move forward. But the test will only be on the information that you see listed in your schedule. Okay, that will go over pretty much what your quiz was over. Okay. Oh, very good. We had like 91%. So labial commissure is correct for that one. And one more. Awesome. All right. Last one. So everybody got that one correct. So vermilion zone was the correct answer. Okay. Hold it on just a second. Okay. So we left off at this area. So I just want to go back over because I was kind of giving you a lot of information right there before we left out. So we talked about the vestibule area. I hope kind of when you go home and you're brushing your teeth now, you pay a little bit more attention to the areas of your mouth and try to figure those areas out, what we see on the screen, and a picture is getting ready to come up. So we'll talk about it a little bit more in depth. And when we come to class, I feel like my main job is, yes, to describe things to you, but maybe to tell you how we use that every day in the dental office so it'll make sense why you're memorizing all this information and how it's utilized. So the vestibule area, and we gave you two terms. We talked about buccal and we talked about facial, because those two terms are up there kind of giving us a description. So when we first talked about lips and we talked about the oral mucosa lining the inside of the mouth, that's a very general term. And I kind of use the sense of maybe where you live. So if somebody asks you where you live, you'll generally just say the town or the city, and makes it real easy. So if you live in Graham, you're going to say I live in Graham, right? Or if you live in Elon, you're going to say I live in Elon. But if you're trying to give somebody directions to your house, you cannot just tell them that, because they'll never find you, right? So for us in dentistry, we can say the inside of the mouth is covered with oral mucosa, but then we get more specific. So when we're charting on a patient and we're writing things down, if they had a lesion or something else was going on with them, then we need to be able to pinpoint that information. If we're in a general practice and someone was to have oral cancer, or we were suspicious that they had oral cancer, we have to give that information over to say an oral surgeon's office, periodontal office, somewhere that's going to take the specimen for us and send that off to the lab. Just like if you were in medicine and they sent you to a specialist for a procedure and then that specimen was go off to the lab, it's the same thing. So in our chart notes and in our letter, our referring letter to the dentist or the specialist, then we have to have that information listed for them. So it's kind of like telling us not just I live in Elon, but where is your street and then what's your physical address on the street, if that makes sense. So that's the kind of difference. And when you think about medicine, we can say things about the vestibule area if somebody had a lesion in the vestibule area, but that's not being very helpful in helping us pinpoint it. So then we can talk about, is it buccal area? Is it the facial area? Is it the maxilla, which is the top arch? Is it the mandibular? Is it to the right? Is it to the left? We would measure it and tell them how large it was at the time. So those are all the bits and pieces of information that we're going to give. And the same thing is true with teeth. And when we talk about teeth and we're trying to pinpoint a very small sized cavity or caries in the tooth, do you guys remember the Explorer and how tiny the tip end of that Explorer is? So we have to be able to reference that information so we're all talking the same language. So kind of think of it as I'm giving you examples, that's kind of your day-to-day and how you utilize that information. So we're going to look at a picture in just a second, but gingiva, the next thing, and what are some of the key things that we talked about? And now you've been back to instruments, so you've at least been able to look at the probe and understand the idea behind the sulcus area and that measuring around that area. Then you found out we do something else in that pocket. What else do we do sometimes? Has its own instrument that looks like a piece of string. Retraction cord, we place retraction cord in that area. So those are things that now you have instruments that relate to that, but there's other things that patients may have an issue with. Some recession in those areas, that means the tissue is going away, a type of infection that might be isolated to that area where they had the popcorn kernel hung and they were unable to get it out themselves and now they're in their dental chair, they have irritation. And again, all of this is going to go in your chart notes, so you're going to need to be able to describe that effectively for any practitioner that comes behind you. So those were the two areas: free gingiva, which surrounds the neck of the tooth, and then the attached. And what did we say about the attached? What is it attached to? Just guess. What lies under that area and what holds your teeth in place? Bone, exactly. Alveolar bone, to be more specific, that we'll get to. But it is bone, and that tissue's attached to the bone. So there's, and sometimes if you eat a chip or a hard food, sometimes it can scrape that area and give you a sore or make that very sore for a few days. So let's look at this picture. I used to have a screen that's so tall. So this is the area here. Does everybody see this area here? Where the attached gingiva and either the cheek or the lip starts, and that's the vestibule area. And as an assistant, we place cotton rolls in this area. That's a big part of what we do every day when we get ready for a procedure. So the vestibule area is where you'll learn to place cotton rolls, along with other things, but that's just one of the things that we'll refer to a lot. So this is we'll talk about this, but you see this here. The term maxillary means upper arch, that we'll talk about in a minute. And then mandibular is the lower arch. And then do you see the vestibule area here? So this would be the buccal, just like it is here on the maxillary because it's on the cheek side. And this would be referred to as facial because it's going to be in the anterior portion of the mouth. And the same thing here, this is going to be buccal because it's in the area of the cheek, just like it is on the maxillary. Okay. So the line here is indicating where the attached where you see that kind of attached gingival area right above the vestibule. And then right around the neck, we refer to this as the neck of the tooth. That's where you're going to have that free gingival space, which we said, if it's healthy, should measure about 2 to 3 millimeters. Do you remember what the depth could be with the probe? That how many lines are on there, or how the hygienist or dentist are going to measure?
2 to 3.
And then what's the greatest depth that it will measure with all the little lines on there? Does anybody know? Depends on which one you had. Easier to see. A few lines or a lot of little lines. So that one, typically they'll measure around pocket depth of 10 to 12, depending on how they set up their periodontal probe. So remember what we said, if somebody had a periodontal pocket that was that deep, what kind of issues does this patient have? Remember us talking about it right at the very end? Just think about if the pocket was that deep around the tooth. So all this, nothing would be attached anymore because that pocket around it would be as long pretty much as your probe. This is what the tooth is going to start doing. It's going to start becoming mobile. This has nothing to anchor it in the bone anymore. All that healthy bone and tissue now is kind of rotting away, becoming necrotic. So when you see commercials about gingivitis and periodontal disease, that's what they're referring to. So gingivitis is typically that inflamed tissue that you see in the mouth where it maybe gets a little red. And we said it could be isolated in one area where the patient maybe got the popcorn kernel hung in that space and could not get it out, or something else could have happened. And what do you see about this tissue that we referred to? What color is it? A pinkish color. And what page number are you on with this image? 131. Okay, and then 130 at the top, because remember we talked about, is everybody's gingival tissue going to be the same color? And we said no, because we all have different shades of skin color. The same is true about the gingival tissue. But we said the underlying color will always be what? Pink, if it's healthy. And then if one of the true indicators, if we were to look in the mouth, if we did not see that pink underlying, what color would it be typically? The red. So if you were to get a cut on your arm and you did not attend to it, you know, the normal treatment, what would you do? If you got a cut on your, a minor cut where you didn't need sutures, but just a minor cut at home or scratch to your skin, what do you typically do?
Put a Band-Aid on.
Okay, anything prior to putting the Band-Aid on? Any ointment of any kind that you can think of that might be helpful?
Neosporin.
Neosporin, anything antibacterial, something like that that you put on it, right? That's how, if we just let it go and we weren't keeping our skin really clean, what's going to happen to that sore, do you think?
It'll get infected.
So what color does it turn? It turns red, right? Because the blood is coming to that area to carry off the infection. So the same thing happens in your mouth. If there's an infection there from not brushing and flossing effectively, whatever our diet happens to be, then that's what causes that very red color to the tissue. It's going to become very red and inflamed because the blood is coming to that area to carry the infection away. So typically what you hear from patients is, yeah, I tried flossing or I tried busting, but then I had a lot of bleeding, so I stopped. So what happens when you do that? Is it going to make it better or worse? It's going to make it worse. So as a dental assistant, we have to show them proper techniques, but also encourage them why they need to brush and floss, and that the bleeding is only for what? And just like if you saw that starting to get red and you got the Neosporin ointment out, what would eventually happen? Typically, it'll start getting better because you're helping the body rid itself of that infection. So the same thing in the mouth. Okay, so those are the signs. And so that's why as a dental assistant, remember, we're seating that patient first. We're going to do typically a lot of times the first visual exam on that patient so we can let the doctor know what's going on. Or they may be there as an emergency patient. So necrotic tissue, anybody ever smell anybody that had very or extreme bad breath? Like very bad. Okay? You don't see teeth that are rotting. Sometimes if you look at their, now you'll pay more close attention, their tissue is really red, then the tissue is dying. And when tissue is dying, it has a very potent smell. Okay, so that's where you get into, we went from gingivitis, that was a little bit of redness and irritation, and we progress into periodontal disease now where teeth are mobile because they're losing bone and tissue. There's nothing to make them stable or sound anymore. Okay, so those are some of the things that we'll be charting on the patient as we look at these. So now we're going to look at another soft tissue, and that's frenum attachments. And we refer to the maxillary arch, which is the upper arch of the patient, and the mandibular arch, which is the lower arch of the patient. And so we're going to have multiple frenum attachments, but we're only going to really concentrate on the two. Maxillary labial frenum attachment, you see here, this area right here. And then we'll look down here. There'll also be one right here in the center that's a mandibular labial frenum attachment. It's much smaller than the maxillary. So now when you go home, you can either torture your loved ones or go to the mirror in the bathroom and everybody can flip up their lips and their lower lip down and you can look at those areas. So the name itself is describing its location so we understand. And I'll give you some incidents in the chair where does this come into play and what's important about this. So maxillary is telling me the upper arch, right? Giving me that information. Labial is telling me what? Right here in the facial area, right? And then obviously the frenum attachment is what we're referring to as that piece of tissue. And then the same thing when we say mandibular labial frenum attachment, we're concentrating on that one that's here in the center, and usually it's very small in size, unlike the one that's typically on the maxillary. So this area here is often responsible for diastemas. And diastemas are this space that happens to lie between the front teeth for some individuals. Their maxillary labial frenum attachment, actually, you see this thick tissue right here? For some people, it's extremely thick, and it goes all the way down in here and separates these two teeth so they cannot naturally come together. Does anybody know anybody that's ever had anything with that before? Sometimes we have people who are familiar with that, either loved ones or other people that you know. So typically, if you want that space closed, some people do not want it closed. It doesn't have to be closed by any means. It's just a cosmetic thing for an individual if they want, or sometimes to get all their teeth to fit correctly. Typically now we use a dentist would use a laser to remove that excess tissue, so when they do close the space, it will not want to open back up again. My son has this issue. So when he was really little, somehow he busted the inside of his lip in the daycare, and they called me and they were all concerned, and I'm like, I just hope it broke the frenum attachment. That would be a good thing. So they were all like, what? So I'm flipping it up, and it did tear it a little bit. I said this might save him surgery in his future, so not having to have that removed. I don't think he's going to get that lucky. But anyway, it's been kind of an issue. So he had to go into early braces, and we have to try to close the space. And so, yes, his frenum attachment has caused an issue from a very young age for him. So it does happen for people. And just remember, the size of it will indicate if it creates a diastema, that space is there. And there are ways that orthodontists can close that. And sometimes they put a permanent retainer on the back of the two teeth if you don't have that tissue removed, but the tissue removal is fairly easy and patients recover very quickly from that. All right, let's see. Does everybody feel pretty comfortable about where the vestibule area is? Again, as a dental assistant, we see a lot of cotton rolls in that area. Attached gingiva, where you see it attached to all the alveolar bone around every tooth from the front to the back, and we'll learn those terms, facial to lingual. You will have tissue that's free all the way around. And hopefully now when you go and floss, when you're at home, you're actually looking down at how far down that floss actually goes, so that you can kind of see when it disappears that we know we're in that free gingival area. The other one that we'll look at is the one for the tongue. I'm going to flip right here to this screen right here real quick. So this is the lingual frenum attachment. Lingual always refers to the tongue side of the mouth. And I do want you to write this down. Sometimes students get a little bit confused with this, so I'll try to go over it and over it again a couple times. So the lingual side of the mouth is the tongue side of the mouth. And we'll talk about the tooth and the tooth surfaces and every tooth has a lingual surface, and that's the side of the tooth that touches the tongue. So whenever you hear an instructor or anyone in the dental office referring to the lingual surface, it's always referring to kind of the back side or the side that's on the tongue side. Now everybody listen carefully. This is where it gets confusing for students sometimes after they leave lecture and they're trying to register everything that was said, or everything they read. That the tongue is not referred to as lingual. The tongue is the tongue is the tongue. The tongue side of the mouth is lingual. Okay, so we've learned a couple terms. If I'm talking about the cheek portion of the mouth, what is this term now? Buccal. If I'm talking about this portion of the mouth in the anterior, what is this referred to as? Facial, or you also heard the word labial today. So labial also means facial. Labial refers to lips. Okay, so those two terms are interchangeable. And I know the little question mark kind of goes over top of your head right now, because we all remember being in class the first time and people throwing out these terms. But for our charting purposes, we use letters a lot, and we can't have two L's. And so when we get into two surfaces, being able to say facial helps with that. So just kind of FYI, the term labial and facial are interchangeable, and we will give you times that we say, in this case, you're going to say facial, and in this case, you're going to say labial. Okay, so those two terms mean exactly the same thing, which is the lip or anterior portion right here that touches these anterior teeth. Then I just gave you that other term that I said was lingual, and that always means on the what side? The tongue side. So the side that the tongue touches, all the back sides of your teeth, that area is referred to as lingual. So that's why the name of this one is the lingual frenum. And we only have one, this lingual frenum. Now what's so special about the lingual frenum attachment? One of the first things they do when you're born is they look at your lingual frenum attachment. Does anybody know why? She's standing up here and it's hard to ask. Because you could be tongue-tied. That means your lingual frenum attachment is really short. So if the baby is tongue-tied and the lingual frenum attachment is really short, they may not be able to eat effectively. So they're looking at that to see if they're going to be able to put their tongue to the roof of their mouth. So they're going to watch that baby very closely to see if they're going to nurse, if they're going to nurse well, or if they're going to be able to take the bottle. And sometimes the bottle design can change depending on the oral structures. Sometimes the lingual frenum will need to be cut so it releases, so that the tongue will come up off the floor of the mouth. So if they don't do it initially, then they're going to look at the child again around probably 1.5 to 2 years of age, because what is the child going to start typically doing around that age frame? They're going to start talking. So sometimes it can cause a speech issue because you know when you talk, your tongue has to touch the roof of your mouth for a lot of the letter sounds that you make, or behind the anterior teeth. Especially when they lose those, like my youngest daughter, they have a hard time forming letter sounds.
Cleft lip, they're missing when they're born.
We will have a class on cleft lip and cleft palate, and that has to do with facial development and how the face develops from the fetal point up into, you know, when there's certain timelines during those developmental stages that occurs. So the lingual frenum attachment, that is not related to that, but we will have a class specifically on those types of things and what the patient would experience, and they do the same thing with the child. And typically, for cleft lip, sometimes palate, they can sometimes see it in an ultrasound. If the mom has an ultrasound at a certain stage, they can kind of look at that and they'll look for that development. So sometimes it can be caught early just so the medical staff and the parent can prepare for what's going to come next. So we will have a whole class on facial development, and that'll be part of that class. So yeah. So with regards to the lingual frenum, we're looking at it for obviously eating purposes, that's important, and then also for speech. So again, that's, again, one of the things that they look at very early on, just to make sure. And then speech for kids would come, much later. So if it did not have to be clipped for the purpose of eating, if the child was able to eat as an infant, perfectly fine, they would not do anything typically to it. And then again, pay attention a little bit closer to when they would start speaking. Okay, I'm going back. Okay, so the next part of the soft tissue area is palate, or the palatal mucosa. So the palate of the mouth is covered with palatal mucosa. Remember we said the mouth is covered with oral mucosa. Now we're giving a little bit more specific to the address or the area that we would be in. Remember the cancerous lesion or the suspicious lesion could be in the vestibule area somewhere. It could be on the attached gingival area somewhere. Or now we could also see maybe on the palatal area something was going on. That would be the stuff that would go into the patient's chart. So the area here that everybody can kind of usually feel, that rough kind of bumpy area, is referred to as palatal rugae. And it's located in the section of the hard palate. So our palate is divided into two areas, the hard palate and the soft palate. We've already kind of referenced the soft palate a few days ago when I talked to you about a gag reflex. So the hard palate is just like the tissue that we know is attached gingiva that we refer to, it's attached directly to the bone. The same thing is true here in this palatal area. You can usually kind of with your tongue feel how hard the bony structure is up underneath that area. And if you take your tongue all the way to the back, you have like a dividing line right here where the tissue becomes soft and it's more kind of feels softer to your tongue. And those of you I said have a hard time brushing your teeth in the morning, or you know somebody that does, you know what I'm talking about? They're brushing away and you hear them about, y'all are laughing, but you know it's true. So the same thing happens to patients. And a lot of the things that we do have to go back that far in their mouth. We talked about impression material, right? Having a tray put in your mouth and that impression material is in there and it hits that and the patient's first reaction is, so. The soft palate is closely associated to the gag reflex. So if I ask you what area of the palate is related to the gag reflex, you're going to say it's the soft palate. This is our body's natural defense from swallowing things we're not supposed to. So your body thinks you're trying to eat the toothbrush in the morning, so it's trying to tell you too far back. Okay? So we're going to talk about how that works a little bit more in dentistry. So in this picture, we really just talked about palatal rugae. We've talked about the hard palate section here and then soft palate. And to kind of piggyback a little bit, when we get into cleft palate, this will be another area that we come back to, and we really study the palate a little bit more in depth because we look at its developmental stages and where these interruptions can possibly happen. But I want to talk about, because our next soft tissue we're going to talk about is uvula. So if you didn't know the official name for the little hanging down thing in the back of your throat, you now know it today. It is referred to as your uvula. So what is this uvula? It's an extension of the soft palate. It kind of has a little bit of muscle there to help us, hopefully, not swallow the foreign object that we're not supposed to be swallowing. So by it being vertical, what happens when we have a gag reflex is that all the muscles in the back of the throat, they tighten up. And so the uvula does the same thing to hopefully block the item from going down the throat. Okay. When I was younger, I had to visit the ear, nose, and throat clinic at UNC multiple times. Anybody ever been there? So, you know, do they still have the cases on the wall of all the things they've retrieved that people have swallowed? It's the most amazing thing. Like, I still visualize it and think, how in the world does somebody get that bottle top like down their throat? Like, absolutely crazy. Big bugs. It's all kinds of stuff in this case that you can walk by. It's like a glass case and look at. Mesmerizing. But anyway, so if your anatomy is working correctly, hopefully it helps you not to swallow foreign objects. Now, we will attest in the dental chair, because everybody's laying on the back of their head like this and their mouth is wide open. If we let go of something accidentally, guess where it's going? To the back of the throat. So we do hope our patients' gag reflexes work in those cases and help bring that crown forward, or the band in orthodontic offices, or whatever it is that we just dropped. So as an assistant, you work really hard not to drop things, but we work in a very slippery environment, so sometimes it happens, unfortunately. Me and Ms. Pruitt had an instructor that went to work at UNC, and one of her last jobs, she was the perfect person for this, we'll tell you, but she was the kind of patient liaison for all of the patients that swallowed foreign objects and had to go over to the UNC hospital to either be radiographed or, yeah, so wouldn't want that job, but anyway, somebody has to do it. But it does happen, unfortunately, but we try to teach you ways, and there's other things that you can do to help keep that from happening, but sometimes it does. Sometimes it just happens to people. I just had this discussion with my kids in the car about like the top to a water bottle, all those things that we know that are just like the exact size that you shouldn't have in your mouth in the first place. So I tried when they were little, I'm like, if it is not food or a toothbrush, it should not be in your mouth, right? So it kind of helps to set that, like, don't put it in your mouth. And then I found at, anybody shop at Academy Sport? Anybody? They have the water bottles that are flips. They look like the little screw top, but they actually flip on and off. I'm like, what? Where's that been all my life? Y'all have no idea, with 3 little kids. So, because they've opened the water bottle and now they've lost the top somewhere, so what do you do with this big water bottle? So the little tops, that's much safer for kids, because then you don't have to worry about them getting it off or putting it in their mouth and potentially swallowing it. So the uvula, that vertical segment of muscle, that's the extension of the soft palate, just really helps us to hopefully block the back of the throat to keep all of those foreign objects from going down the throat. So as a dental assistant, one of our big jobs is to try to help patients that already have a gag reflex, maybe overcome that, or help them be as comfortable as possible when they have to do procedures that are going to elicit the gag reflex. And if anybody's ever had the radiographs done, anybody in here have a pretty heavy gag reflex, and when they do that, you have a hard time being still and not gag? Yes, it's pretty common. So it's helping your patient work through that, and those are some of the tricks that we'll give you as you move forward. All right, so the tongue. Let me also, let me see. Yeah, I'll go one more. Okay, I'll wait to the slide. All right, so tongue. Would you also agree it's a soft tissue? You ever bit it while you're trying to eat, or you've done anything else? And it's very alive and well. It does assist in mastication. That is a very fancy medical term for chewing. Also, obviously, swallowing. And most of all, we are probably all very familiar with the sense of taste. Also, we could add in there speech. Would you agree to that? In order to be able to talk, it really does help to have your tongue. We had a family friend that was exposed to a lot of Agent Orange when he was in the service, and when he came back after multiple tours, years later, he ended up losing very large portions of his tongue to oral cancer, not just including lots of portions of his mouth. But the tongue was really hard. and watching him was really tough. Sweet, sweet gentleman. Swallowing, this is really what it sounded like all the time. So then he's using his cheek muscles to help move the saliva because he didn't have the tongue function anymore. And whenever he spoke, and you always try to involve everybody in on conversation, you had to pay attention very carefully because his speech was so much more difficult for him because pretty much both sides of the tongue were missing for him. So a lot of his tongue was removed due to oral cancer. When we look at the tongue, we have the dorsal surface, which is the top surface of the tongue, and that's where you're going to see the papilla. When you stretch out your tongue, if you've ever had one get inflamed or infected or something like that, that can be very irritating, last about a day or so. And the ventral surface is going to be the underside of the tongue. So let's look at the pictures here. So at the top up there, y'all see the papilla, and also fungiform is represented there. And then here on the ventral surface of the tongue, that's where what is located. What is that called? The lingual frenum attachment, right. So remember, when we have patients come in our office, if we were to discover a lesion or something suspicious on the tongue, then we'd have to chart what surface of the tongue it is. That's how you're going to utilize these terms on a day-to-day basis, or if anything's going on or a patient has a concern about something. If you work in an oral surgeon's office, periodontal office, something like that, where they may actually remove a portion of the tongue, then that part would have to be labeled. The specimen would have to be labeled correctly for the lab. So some of these terms would go down on that as it's sent off to a lab for testing as well. Or if we were referring to an oral surgeon's office from our general practice, then all of that information is going to be would be listed on what portion of the tongue, what side of the tongue it is, whether it's dorsal or ventral, and then all of the other information that they would need to know. Like, again, giving those directions. Right, left, and what portion of the tongue, and all that stuff, and where it was located. Okay? All right, so I think it's probably a good time to take a break. So we'll take a 10-minute break, and when we come back, we'll pick up the rest, a little bit more that we have of soft. Okay, for the last bit of material for this section before we move into hard tissue, we're going to talk about the oral pharynx, and I'm just going to cover the things that they require that we cover. And my biggest statement to you is this is where everything in dentistry ends, and this is where we refer out to an ENT doctor that we were talking about earlier. Okay, so we do not do anything in the territory of the oral pharynx, but during a dental exam, if the dentist was to see something suspicious in this area, that's when the patient would be then referred to the ENT doctor. Okay, and then I'll talk a little bit more about the uvula and the soft palate just a little bit. So the tonsils lie on either side of the throat at this point. How many of you are familiar with tonsils? If you've ever had tonsillitis or tonsils out, or you know somebody, that's quite familiar to most people. So remember, this is what you're writing down. This is kind of where the oral cavity ends and the oral pharynx begins. And remember, if you're going to have your tonsils out, you're not going to the dental office, you're going to go to an ENT. And that stands for ear, nose, and throat. And just these two areas, and we'll look at a picture real quick, palatal-glottal arch and palatal-pharyngeal arch. Those two areas are kind of the fold areas that you see in the tonsil region. And that's just kind of showing you the outline of where the oral pharynx actually begins. So at this point, the oral cavity ends and the oral pharynx begins, and that's when we refer people to the ear, nose, and throat doctor, or ENT. For some reason, people tend to flip-flop one way or the other. Either they go to the dentist sometimes and they don't go to a medical doctor, or they'll go to a medical doctor and not go to dentist just due to apprehension sometimes. Sometimes it's financial. But when we have a patient in the chair and the doctor is doing an exam, they're going to look at all this area and observe it visually when they're doing their exam to look for any possible lesions. Can I turn this sleep just so we can look at the pictures? Okay, so you can see palatal tonsils there. Anterior pillars, posterior pillars, these are all the folds that we're looking at right before the pharynx, or the posterior wall of the pharynx. There is not really any labeling with regards to this. I don't belabor this on a test other than you understand this is where the oral cavity ends and the oral pharynx begins. One of your sheets for like your worksheet, your practice sheet, it just has some little tonsils drawn in. So as long as you know where those are, just so you can kind of understand where the ending of and the beginning is, that's fine. And it's just a little hand drawing, and that's it. All right, so hard tissue. One of the first things that you looked at with hard tissue were the teeth, and we looked at teeth tissues and all that kind of stuff on your quiz. And we'll see how far we get with all this today. But these are just some facts that you need to write down with regards, or you can, the slide will be open and you can save your hand, either way. So for teeth, we have two sets of teeth. We have deciduous or primary. Those two words are interchangeable. And then we have permanent. So how many teeth do we have in the primary or deciduous set?
20.
20. So all children should have 20 teeth. 10 in the maxillary and 10 in the mandibular. And then once we're adults and we have shed all of our primary teeth or deciduous teeth, then how many teeth should I have?
32.
All right, so how many in each arch? 16. So the other thing that you see here is the picture also has it divided into quadrants. So how many quadrants do we have?
4.
4. And they're referred to as maxillary upper right, and then this is the maxillary left, which is on the upper. We have mandibular left and mandibular right. Sometimes in dentistry, we do things in quadrants. If we have patients that have numerous restorations, say in the quadrant over here, and we're going to anesthetize this whole quadrant, we're going to try to have enough time to get all of those restorations filled in at the same time while that patient is numb. So sometimes we refer to that as quadrant dentistry. For an assistant, you may also be taking quadrant impressions, just one impression of that quadrant, or scanning just one quadrant. Those will be the things that you see written on your daily schedule or in the chart as instructions for what you need to do, depending on the procedure. When you're ordering supplies, one of the supplies that you may order would be those quadrant impression trays. Just give you an idea of how we use these terms and what we're looking for. Again, just giving us directions. Any questions about this screen so far? It kind of keeps building, but just to start out. Okay, so let's look at tooth arrangement, where the teeth are arranged. And we're going to start with the anterior portion here, which is also referred to as facial, or we know also labial. We have incisors, our central incisors, both here on the maxillary. Everybody, those are usually very recognizable because they're the largest teeth you have right there in the anterior. And typically the smallest ones are going to be the two mandibular central incisors. So what is the job of the incisors? Kind of like its name. Incise or cut, right? So when you go to eat that sandwich, where do you typically put the sandwich when you go to bite into it? Right in the anterior portion, and you incise the size piece that you would like off of the sandwich, typically when you bite into the sandwich. So that cutting motion, incisors. What is the other incisor? Does anybody know the name? The one right beside the central?
Is it lateral?
It is the laterals. So those two kind of work together. And we also have laterals down here on the mandibular as well. So the laterals are right beside, they're neighbors to the centrals. So incisors are made up of centrals and laterals. And their job is to incise or to cut. And then the last tooth that we would see in the anterior is going to be which one? Canines. And what's the job of the canines?
To cut and tear.
So, and we're going to kind of grasp. And so sometimes I use these illustrations of, nature shows where we watch big cats. So these teeth here, and then here on the lower, we'll learn all their tooth numbers shortly. But if you ever see a big cat go after prey, they tend to grab them with those large canines that they have, and they can hold on to them. So canines, if you think of grasping and holding, sometimes that helps us remember it. But I first started out with a simple sandwich, one that you would make at home with normal loaf bread. And then sometimes there used to be Bruker bagels in town more than they're not as popular now, I guess. But anyway, it used to be a place that everybody could eat. So if you like a bagel, typically bagels, those harder kind of newer style bagels, you can't just incise it with your anterior teeth. You tend to have to, and sometimes hard rolls are the same way, tend to take it over to the side just a little bit and grasp it with your canine and do more of a tearing motion to actually break a piece of bread off, something like that, so with the harder roll. So that's kind of in the anterior, you kind of think how we use our teeth. Those canines are very important in the process of eating just as well as the centrals with regards to tearing into stuff or grasping hold of it. So let's look at the posterior teeth. The first ones we'll look at will be the premolars. And each quadrant is going to have 2 premolars, and you can kind of see those sectioned off there, and then down here they're pink, and then on this side. So every quadrant will have 2 premolars. We'll learn those, they're first and seconds, but we won't belabor that today. We're just trying to kind of learn the positioning of what's in the anterior and what's in the posterior. So posterior teeth consist of premolars, and what's the job of the premolars?
Just a sec.
Yeah, kind of holding and grinding. They kind of assist the canine a little bit, and they assist the molars. So they're kind of in between the canine and the molar, and they kind of help the molars and the canine do their job. We slide over just a little bit to grab a hold of that stiff bagel, and we go to tear that piece off. Usually part of the premolars kind of helping you do that job. Our molars, which are the most posterior teeth, and how many molars do we have on each side? 3. So each quadrant has 3 molars. They're first, second, and third molars. That has to do with eruption. This is another day's lecture, so we won't try to belabor it too much. But to understand, molars are typically where we grind all of our food when we're eating. Those are the teeth that we use primarily. So guess what teeth, as dental assistants, we spend the most time working on? Anybody want to guess? Molars. Yeah, they take a beating. The other thing about them is they're so far back in the mouth for people to properly brush and floss those areas. It's a little bit more complicated. And unfortunately, they probably don't spend as much time as they do on the anteriors where everybody can see them. Does that make sense as well? It's a little easier to brush in this area and keep them flossed and healthy than it is in the posterior. But the posterior is getting all the food particles, a lot of that carb that's breaking down into sugars, a lot of that happens. And then we also have, which we don't have in the anterior that we talk about, a lot of grooves and other developmental things that are going to trap some of those bacteria and then end up causing caries. Okay, so that's one of the other things that we look at in the posterior. So a lot of your career is spent in the posterior of the mouth, which is obviously the more challenging area to usually work in. It's farther back, it's closer to everyone's gag reflex, right? All the things that we were just talking about earlier, we're going to kind of see that in the posterior. So remember, anterior are incisors and canines, which are centrals, laterals, and canines. And so anterior, we usually say, is canine to canine. That's just the easiest way to remember it. So the anterior, whether we're talking about maxillary or mandibular, is referred to as canine to canine. And posterior would be the premolars and molars. So a lot of times when you're given instructions by your faculty member, whoever it happens to be, and we call it anterior, you want to place that dental dam in the anterior, then you already know I need to expose at least canine to canine. All right, so now we're going to look at tooth division. We're going to look at that individual tooth. And we're going to look at the crown portion. This was chapter 8, figure 816 a while back. Does anybody see that in their textbook? This same image. I think exactly the same. The number might have changed. This will be one of these concepts we kind of have to drill over and over again, and I'll kind of come back to and explain over and over again. The crown and the root are going to be broken down into two different things. It's going to be anatomical and clinical. So the anatomical portion of the crown is covered in enamel. That's the first thing that we need to recognize. The anatomical portion of the crown is covered in enamel. And I've looked at some of these tooth tissues now, but so the clinical portion of the crown is everything that I can see with my eye when I look into the patient's mouth. So the clinical crown is when I look in the patient's mouth, every part of that tooth that I can see with my eye is now referred to as the clinical crown. So this picture does a really nice job of dictating that for you. So the first one in A is referring to the anatomical crown. Can you all see where the white ends and the yellow begins? So I know that the yellow is really its anatomical root, but in this case, I'm just referring to the anatomical crown, which is all the white enamel that you see. Now the clinical crown, when I look in this patient's mouth, I can see all the way down to where this gingiva has receded, and we see how this one, you can still see the crown, and you don't see any of the yellow portion of the root. So there's still maybe some slight anatomical crown here that's underlying this tissue. Usually the tissue is up above where the anatomical crown is, but sometimes there's major recession. And as we get older, we tend to have more recession. Just the tissue starts kind of going away with wear and tear. So just remember the clinical crown and the anatomical crown. So the anatomical crown is the portion of the crown that's covered in enamel, and the clinical crown is when I look in that patient's mouth, any part of the tooth that I can see is going to be referred to as the clinical crown. Because clinically, I'm going to have to take care of this whole area here. Maybe that'll help you remember that a little bit more. And the anatomical portion is a portion that's just covered in enamel. All right, so we're going to look at the root same way. Roots can be single or multiple. So teeth can have one single root, they could have two roots, or they can have up to 3 roots. So the same is true with the root. The anatomical root is the portion that is covered by cementum and remains in that alveolar process. And the alveolar process is the bone that each tooth is embedded in, that the maxilla and the mandible are made up of. That is referred to as alveolar bone. The clinical root is that portion that's unerupted, that remains down in that bony area. And for children that have teeth that are erupting, obviously it's going to be much larger for them. And as the tooth comes in, that will lessen. For those of you that had radiology, we talked about the apex when we talked about taking a periapical and some of the things that we needed to see on our radiograph. The apex is the terminal end of the root. The very tip end of the root is referred to as an apex. Those of you that had radiology on Monday and Tuesday, do y'all remember that? We had to have that for the centrals and the laterals, the apex. The central, that was like our last line item that we had for our radiographs. Any question about that? I'm just going to go back to this slide one more time. So the anatomical crown is the portion of the tooth that's covered in enamel, and the clinical crown is what I can see with my eye when I look in there. And so for some kids that have teeth that are erupting, it's very, very small because the tooth is just now coming through. So my 7-year-old is getting her permanent molars in, her first molars, so I can see very little of it. But that would be all I can refer to as a clinical crown because it's all that I can see with my eye right now. Okay, so that sometimes it's larger and sometimes it's smaller, depends on the patient and how much that tooth is erupted. All right, do these terms look familiar after your quiz? Okay, very good. All right, so enamel. And we just said that it covers the crown of the tooth. Did you learn anything else about enamel when you were answering that question during your reading? It is the hardest living tissue. Make sure you put in there living. Those of you that worked with Dexter in room number 307 that I demonstrated on, please raise your hand. What did his front teeth look like?
Messed up.
So what happens to enamel once it has no life-giving properties anymore? Becomes very brittle and it breaks very easily. So Dexters have to have extra special care, but it just shows you. I went from the hardest living tissue now to something that's very brittle. And I'll expand on that just a little bit. All right, so what about the dentin? What do we learn about the dentin? You may remember a fact about it.
Is it the softest?
It is soft. It's not the soft, but it is softer than enamel. It lies under the enamel and also under the cementum of the root. It makes up the bulk of the tooth. If you look at the picture over here, the bulk of this tooth is dentin. Okay? That enamel is kind of our armor against hopefully the bacteria that wants to try to invade our teeth and cause cavities or caries. By the way, those two terms are interchangeable. So that hardened shell, that nice hard enamel, tries to repel everything and keep it away. Dentin, though it still has properties of being hard, it is laid down in tubules, so it has kind of openings or holes in it if you saw those pictures in your textbook, where enamel is laid down in rods. So let's look at those pictures real quick. Somebody finds it before The one over here, yes. 88. We have a winner, 88. in those two pictures, you can see the difference. It has to be microscopic. So under, on page 88, what's the figure numbers? The figure numbers, it'll say like, underneath the picture, it gives you like a number on the side. 819 and 820. Okay. So 819, 820. So you see how tubules have like the big holes when you look at it under a microscope? And then when you look at enamel, it's like little tiny rods and they're all stacked on top of each other. So that's how it looks if you were to scan it with the microscope so you can understand this. And when you get into dental materials with Ms. Pruitt, she's going to use these terms again because as we apply things like composite, do y'all remember what composite is? This is like Jeopardy. You know what amalgam is? What color? It's the silver filling material, or restorative material. So what is composite? The tooth colored. Yeah, the tooth colored filling material. So how we make the tooth colored filling material stick to the tooth surface has to do with dentin tubules, and also they'll talk about enamel rods. So those are two very important terms when you're speaking about enamel and dentin, because then you can understand that. So if you look at the two of those, once the bacteria from the decay makes it through the enamel and now into the dentin, guess what? It moves a lot faster. We call it kind of like wildfire. It moves very, very quickly. Guess where it's headed? What's the next tissue that we're going to look at?
Pulp,
The pulp. Now, what is the pulp of the tooth?
nerve, blood.
Nerve and blood supply. So the time that you have had some ice cream, or my husband bites into ice cream, I still don't understand it. It drives me crazy. He obviously has no, I don't even like ice in my drinks, like it sets my teeth, goes crazy. So the nerve is telling you, usually, the food is hot. Typically with our teeth, it's food is cold. Therefore, anybody bite into ice cream? I tell them it's not normal. So he bites into ice cream, it just gives me the chills because I can just feel it in my teeth. Okay, so the nerve is alive and well when it can tell you and register hot and cold. Okay, we want the nerves to be alive and well because we just talked about the dexters that do not have that anymore, and now their teeth are breaking. It's no longer the hardest living tissue. Unfortunately for some patients, though, the decay makes it all the way to the pulp. And so we have it divided into two areas. A few areas, sorry. The pulp horns, you see those kind of up. The pulp chamber, and then we have what? Pulpal canals. So this is how the blood and nerve supply comes into the tooth. It's embedded in the bone. It comes up at the what portion of the root is this that we just learned that term? Apex, because it's the tip end of the root. Has an opening here. And so when the decay comes here, our body's natural defense is that pulp horn will start backing away. It's going to start moving away from the decay. It knows the wildfire is coming, and the tooth will naturally try to protect itself. And it lays more dentin, and the pulp moves. But sometimes the wildfire still gets to it. And you've seen that, unfortunately on TV, people out there trying to keep their houses from burning and other things. So sometimes the same thing happens in the tooth. It moves very quickly through the dentin. It gets to the nerve. So unfortunately now the nerve is going to die. This is when anybody ever know, maybe you've had one, a toothache. It's extremely painful. And you have that throbbing. And if you've never experienced it, for your patients that do, be very sympathetic. So anybody hear of a root canal? Everybody always says crazy stuff. Okay. So root canals, and we'll study these, especially when we get into instruments, but the actual dead nerve tissue or the nerve tissue that's dying will be removed from this area, and we have another kind of fancier filling material that we can fill that with. I'm saying all that because you've heard us talk about crowns this week when you looked at the crown and bridge setup. So if that tooth has had the nerve removed from it because it was dying, decay got to it or something, injury, something happened to it, then we got to put a crown on that tooth, because if we don't, they're going to end up looking like the dexter. We're going to bite into something and the tooth is going to start crumbling because it no longer has the nerve and blood supply to keep it alive and make it that hardest living tissue. Okay, so the pulp is the softest. If you think about it, and I try to warn you the first week of class that we talk about this, because somebody missed that years ago whenever they were taking class, and the first time they saw a tooth opened up. Okay, so we go into the tooth. You're going to learn about handpieces and rotary instruments such as burrs. We go in to remove the decay. If it gets down really close, sometimes we hit the pulp or we get into the pulp because the decay's gone that far. So let me just tell you, when you look inside the tooth, if it's a healthy tooth, if it breaks, something happens, it bleeds. Because we just said that's blood and nerve supply in the tooth. So it's going to be red. It's bloody. So when they go to do a root canal on a tooth that the nerve has not completely died in, if it has, then it's going to look like dried blood. It's going to be more of a brownish color, just like if you were to have dried blood from an injury. Okay? So I don't want you to be shocked and surprised and say anything in front of your patients the first time that you see that. So I do want you to understand that if we were to go inside the tooth today, we go straight down to the nerve, it will be red and it is blood. And that circulates in and out of your tooth just like the rest of your body, and that's what keeps your tooth vital. So if we don't have that anymore, then that's a patient that's going to be referred to for a crown. So if they're having to go to the endodontist for a root canal, or they're in the private practice and the doctor does root canals there, then the next, remember the treatment plan that we were going to do for our patient? The next portion of their treatment plan would be to crown that tooth. So we can put something on it to protect it from breaking. That's what we do with the crown. We kind of cover it up. We take away the broken down parts of that tooth, and we try to put it back together the best possible. Anybody thinking in their head, why do we go through so much trouble? Why can we just not take it out? And there's a lot of patients that have to elect to take it out, or they do take it out. Does anybody know the answer to that? Can you just guess maybe? They have things like implants now, which is a good thing. It's always better to keep your natural dentition, whatever part of it we can keep, even if it's the root and just part of the crown, and we put a crown up from lab. It's always better to keep your natural tooth structure than to put something else in. Implants, bodies can reject those, just like you hear for people doing hips and knee surgery, things like that. So it's always better to keep as much natural tooth as we possibly can. Okay. So these are the 3 breakdowns, and this is all the pulp. It's just different parts of the pulp. Remember, in our chart, if we're charting for our patient, then we may say the pulpal horn on either, I don't know these terms yet, but mesial or distal, those types of things are where we see that recession. These are things that we're charting, or that the decay is already into that, or we opened the pulp chamber today because we weren't able to complete the root canal. These are things that you will be typing in the patient's chart. What the canal size was when the root canal was done, the finished, beginning finished, all of this stuff is dictated in the patient's chart. That's information. All right, the next tooth tissues that we're going to look at is cementum. So what is cementum? What part of the tooth does it cover? The roots of the tooth, that's right. So enamel covered the crown, and the outside barrier of the root is cementum. And obviously the inside portion is either the two that we talked about, either dentin or the pulp, but dentin still makes up the bulk of the tooth. Now, the alveolar bone, okay, alveolar bone, it's also referred to as alveolar process because when we study head and neck anatomy, and we look at the maxilla and we look at the mandible, one of the processes that we'll look at will be the alveolar bone process. So it's referred to in dentistry as either alveolar bone or alveolar process. Do you remember what I said about patients earlier that had periodontal where the bone and the tissue started going away? What started happening to their teeth? That's right, they became mobile. So one of the other things the hygienist and the dentist are going to look at is, are any of the teeth mobile, and what is their mobility? When we start having deep pockets around the tooth, they're going to start saying, they're going to use their finger instrument and start trying to move that tooth to see if there's some mobility. We have to record all of that in the patient's chart. So the alveolar bone gives us that support or stability so that the teeth don't move. So what's the job of the periodontal ligament? So this is the job of somebody just said, to support or suspend that tooth in the bony socket. So we don't just have tooth on bone. Around that outside cementum is periodontal ligaments that actually attach to the bone and kind of act like little bungee cords. If you've ever seen anybody ever done that? Maybe that's a better question. Jump off of anything with the bungee cord attached to you? I just want to know if there's any daredevils in here. I hate heights, so you can assure you somebody would have to sedate me, drag me up there, and push me off. There's no way. Does everybody have that so we can look at a picture? All right, so let's look at this picture. So the outside portion here is representing alveolar bone or process. This outlying area of the root would be the cementum. And then all these little fibers here that you see are going to be what?
Periodontal ligaments.
Yes, periodontal ligaments, periodontal fibers. Has anybody been eating something that was supposed to be a soft food and you're just chewing away and then all of a sudden you bit down, it was hard, and then your tooth was aching because you were biting so hard on that soft food? Like when you're chewing hard foods, it's a little different. It's a different amount of pressure that we put. So usually what happens is the tooth is jammed down against the bone. We've kind of overstretched those fibers and it pinches the end where the nerve ending comes in. So it sends you kind of that electric shock feeling sometimes. So these periodontal fibers or ligaments actually act as shock absorbers as we're eating and chewing things to help protect the tip of the root, the apex where the nerve comes in, so we're not constantly causing damage. Do you remember Ms. Pruitt talking about articulating paper in the holder? So when we put a restoration in a tooth and we're going to have the patient do what? Bite down and grind around. We want to make sure that that restoration is not too high, because when they leave, they're going to keep pounding it, and guess what they're going to come back with, or they're going to call us with? Their tooth is hurting. We can't keep pressing on that nerve and causing trauma without having an ill effect of that. Does that make sense? And so those periodontal, how many of you have braces or any type of aligners? Sometimes when you go to the hygienist and you have your teeth cleaned and you leave and you're like, my teeth are so sore, like you don't want to eat, or you've had orthodontics done and your teeth are super sore when you go to bite down. Well, what they've done with all those brackets and wires and all the colored little bands is they're taking those teeth and they're twisting and turning, and when we're doing that, we're taking those periodontal ligaments or fibers and we're tearing them. So guess what they have? They also have nerve sensation. So we've made the area in our mouth very sore. And then as they recover and repair, as the tooth moves slowly, then the soreness subsides. And then it's time to go back and visit the orthodontist again, right? And it starts all over again until you get to the final stage. Teeth cleaning, usually a day or two, your mouth might be a little bit sore where some of those fibers were broken during the cleaning process, trying to get out the calcified material that was left in the mouth. Any questions about this? You should be able to label a picture that looks like this. You should be able to tell me that this outer area is alveolar bone or process. You should be able to tell me these little fibers are periodontal ligaments or periodontal fibers. The outside material on the root is cementum. The interior portion here that we talked about is dentin. Then we have the pulp of the tooth, and last but not least, the enamel portion. So you should be able to indicate all those different tooth tissues. And your books have some pretty good pictures. Yeah. And there'll be one lecture that we really talk about periodontal ligaments a lot more in depth, but this is to just kind of give us the breakdown of the different tooth tissues. So the hardest tooth tissue is which one? What did we say today? Enamel. And the softest tooth tissue is pulp. Good. Let's see what my first question is. See, I gotta wake it back up. Can y'all wake your phones back up? I want to make sure y'all see it when your phone's way back up. This is going back from a little bit ago. See if you can answer this one.
What's the website again?
Socrative. And the question is, in case you don't have it on your phone, you want to write it down, because it's not on the screen. The clinical crown is seen above the gingiva, and it's a true false. So, true or false, the clinical crown is seen above the gingiva. You can tell that students struggle with this concept, so I'm just going to keep saying it over and over again. So we're thinking about the clinical crown, which I can, that's your hint.
That's the wrong name. It's the auditorium. Oh, I don't know. What's the room name? I'm so sorry.
The room name is Roberts, all
Sorry.
caps, 7260.
Thank you. I wasn't sure. I knew it was her name, but
Yeah. If anybody can think of any questions now while we wait on everybody to have a chance to answer, ones that you can think of. I think we're all on Remind now, so over the weekend, if you have questions, you can always reach out to me. I'll do my very best to answer. It's a little easier for Remind because it comes to my cell phone. I do try to check my emails because I know y'all have quizzes and stuff, so don't be afraid to ask. I think that's everybody. Okay, so it is true, the clinical crown is that's seen above the gingiva. Anything that I can see that's above the gingiva is the clinical crown. All right, your next question is up, in case you're not on your phone. This one is contains nerve and blood supply. So what tissue contains nerve and blood supply? Awesome, 100% on that one. Good job. All right, the next one is up, provides the support and stability for the tooth. So it provides support and stability for the tooth. Awesome, alveolar bone, 100%. Good job. So, your next question is makes up the bulk of the tooth. Okay, so for this one, the answer is dentin. So the tooth tissue that makes up the bulk of the tooth is dentin. Okay, now close that. Okay, so remember, that's probably likely going to be a test question. So just remember the bulk of the tooth is made up of dentin. Okay, So, let me see. I know we've got radiology next, so we've got to get out of class. But I do want to, we will cover this on Monday. But I do, as you move forward, I'm going to loosely cover these terms real quick, and then we'll do it more in depth. But just as you're helping you read and understand, because I know that you went over these for your quiz, we'll spend a little bit more time on them because this is sometimes a concept that's a little bit more challenging. We already discussed lingual. So every side of the tooth has a lingual surface. Every side of the tooth has a facial surface, because we can go on both sides. So we have lingual on the tongue side, and we have facial that either touches the lips. So we say facial, but it can be more specific by saying labial for anterior teeth or buccal for posterior teeth. We either have occlusal surfaces for posterior teeth, and we have incisal edges for all the anterior teeth. The hardest concept probably for most students to grasp is mesial and distal. So I'm going to go over that real quick with you before I dismiss you. So mesial is going toward the midline of the mouth, and we know the midline is between the two central incisors. The distal is going away from. So this side of the tooth here is referred to as mesial. This side of the tooth over here is referred to mesial. So we just keep, all the teeth have a mesial surface. So on this side, it's going to be this side of the tooth that's closest to the midline, mesial. When we're looking at distal, it's going to be opposite of mesial. It's going to be farthest from the midline. So all of these teeth, the distal surface is here. So even if I go up here to, what's this portion going to be referred to? Which one? Mesial. Same thing for here. What about this side of this first molar? Distal, because it's away from the midline. So if we're looking at the central incisor, what is this side going to be? Mesial, because it's, this one's, we're lucky, it's touching the midline. So over here, distal. So for all the teeth that have two surfaces, they're all going to have a mesial, they're all going to have a distal. They're either going to have occlusal or incisal, because it's going to be their posterior anterior, the part that we chew on or bite with. And they're all going to have a facial and a lingual. And facial we can be more specific with by saying buccal or labial. So when we come back to class on Monday, I will show you how we use those terms every day, and make more sense of them. But as you're moving forward and reading, that will help a little bit. And I promise we'll spend much more time with that, and I'll show you how in your day-to-day operations you use those terms all the time. I will open the quiz up for the next quiz. I think we have one. I'll check it and see, and if not, I'll send you a little note, because I know we were supposed to have a test, but I'm going to try to move forward with some of the information that may not be on a test, so we don't get too far behind. Okay? If you have any questions that you do not want to ask in class, you can always see me after, or open lab time is now for those of you that do not have radiology, so you can also see me then if you need to as well. Okay? All right, y'all have a great weekend.